Hi, everybody. My name is Jim Krismali. I'm one of the transplant hepatologists at Mount Sinai. And myself and Dr. Chris Woodrell, who is a palliative care and geriatrics physician who has a specialty in the palliative care of patients with liver disease. We're going to be taking you through a whirlwind tour of hepatology for the geriatrics and palliative care clinicians. We'll try to cover the most salient points um, for your patients. So neither of us have any disclosures relevant to this talk. So when we talk about chronic liver disease and when we try to think about the context of patients who have symptoms related to their liver disease, we're really talking about patients who have advanced liver disease and most often decompensated cirrhosis. As most of us are aware, cirrhosis is the end stage, really any form of chronic liver disease. Anything that causes chronic inflammation within the liver can lead to ultimately fibrosis and scarring. And ultimately, that culminates in the end stage of fibrosis, which is cirrhosis, with nodule formation within the liver, portal hypertension, and synthetic dysfunction. The most common causes of advanced liver disease in the US currently are alcohol-associated liver disease and metabolic dysfunction associated steatotic liver disease, which is the new nomenclature for non-alcoholic fatty liver disease. We still see end-stage liver disease related to chronic hepatitis C and chronic hepatitis B, although it's much less common than in the past. And again, the symptoms that are really manifest in end-stage liver disease are really related to the presence of decompensated cirrhosis and to the development of hepatocellular carcinoma, for which patients are at risk once they develop cirrhosis. When we think about cirrhosis, it's not sort of a monolithic stage in the sense that most patients, when they first present, will have compensated cirrhosis. And this stage of compensated cirrhosis can actually last for up to 10 to 12 years. Patients may have no portal hypertension or they may have mild portal hypertension, but they haven't yet developed the overt symptoms that we think of when we think about cirrhosis. And so those symptoms, things like variceal bleeding, ascites, and hepatic encephalopathy, are really what define the development of decompensated cirrhosis. And this is an important stage transition because once patients develop decompensated cirrhosis, their overall survival drops from between 10 to 12 years down to around 1 to 2 years. And then once patients develop decompensation, they're at risk of further decompensation with things like refractory ascites, hepatorenal syndrome, and recurrent variceal bleeding. And in this stage, without liver transplant, they're at a very high risk of mortality. And because many patients don't have access to liver transplant, many of our patients wind up needing palliation for their symptoms at this point. So now when we think about estimating the severity of cirrhosis, there's a few different scoring systems that we utilize. The classic scoring system is the Child-Pugh score, and that incorporates 3 different lab values, the bilirubin, the albumin, and the INR, along with 2 clinical parameters, ascites and hepatic encephalopathy. And based on these different parameters, patients get a number of points, and then based on that number of points, they get assigned into a Child-Pugh class. So Child-Pugh A generally corresponds to patients with compensated cirrhosis, whereas Child-Pugh B or C usually corresponds to decompensated cirrhosis. Now, there are some issues with the use of this staging system, namely, there's a big ceiling effect. So someone who has a bilirubin of 4, for example, gets the same number of points as someone with a bilirubin of 40. So there's not too much granularity in the Child-Pugh score. We more commonly use the model for end-stage liver disease, or the MELD score, and its variants to help estimate prognosis for patients with end-stage liver disease, and also to help allocate organs so that we give patients who are the sickest the first chance at transplant. Something that's not really captured well in either of these scoring systems is frailty, which we're seeing really impacts both quality of life as well as survival, both pre and post transplant. And so we'll review some data looking at where frailty fits in kind of the risk stratification for patients with cirrhosis. So the MELD score was actually originally derived to estimate 3-month mortality after portosystemic shunting procedures or after a TIPS procedure. And the original MELD score included parameters including the creatinine, the INR, and the bilirubin. And actually, in its original conception, also included the etiology of liver disease, although that isn't included any longer. Subsequent to its use for assessing risk for decompensation after TIPS, it was found to be predictive of 3-month mortality among patients waiting for transplant. And so in the early 2000s, about 2002, this was adopted as the primary scoring system used for allocation. So patients with a higher MELD score, which caps out at 40 for the purposes of allocation, get offered transplants first, and people with lower MELD scores get offered transplants later. There have been a few modifications to the MELD score over time. In 2008, data were published showing that incorporation of serum sodium into the MELD score improves the prediction of mortality, and that's because, as we'll talk about, hyponatremia is a feature of advanced cirrhosis and advanced portal hypertension because of the activation of the renin-angiotensin-aldosterone system and the non-osmotic release of vasopressin related to low effective circulating volume. And so many patients with advanced portal hypertension wind up becoming hyponatremic. And so this serves as a surrogate for severity of portal hypertension. And so this was incorporated in organ allocation in 2014. But even with this modification, there are some criticisms of the MELD score. I mentioned that, these are just sort of lab-based tests. So they really reflect synthetic dysfunction, and they don't always reflect the severity of portal hypertension. So there's no there's no cofactor in there or covariable in there for ascites, hepatic encephalopathy, variceal bleeding, sarcopenia, and some of these other complications of advanced liver disease. And so there are patients who wind up being disadvantaged by the fact that we utilize the MELD score for liver transplant because we're not capturing all of their symptoms and the impairments in their quality of life. In addition, the serum creatinine is very heavily weighted in all versions of the MELD score, and this can put patients who have low muscle mass, most commonly women, at a disadvantage when they're waiting for a liver transplant because they may not mount as high of a MELD score as their male counterpart who may be equally as sick. And so, there have been subsequent modifications, which we'll review, to the MELD score that have tried to account for that. And as I mentioned, the current MELD scoring systems don't capture frailty. And so we often are left with this sort of category of patients who are what we call sicker than MELD, where they may have a relatively low MELD score for the degree of their portal hypertension or for their degree of sarcopenia. And this becomes a problem because then these patients don't have equal access to transplant, even though they may feel a lot sicker and have a more impaired quality of life. So this is the most updated version of the MELD score, the MELD 3.0, and this was put into use for allocation just last year. It seeks to address some disparities in transplant. It now incorporates a sort of corrective factor for female sex, and so this kind of tries to equalize and correct for the fact that most women have lower baseline creatinine than most men do. And it also incorporates serum albumin, which is a marker of nutritional status, but also a marker of synthetic dysfunction. And so these factors are added to what's already in the MELD score, the bilirubin, INR, sodium, and creatinine. And the modeling using this scoring system suggests that this helps to assign more women a relatively higher MELD score and helps to equalize access to transplantation for many of these patients. Again, even with that, even though we are incorporating albumin, which again is a weak marker of nutritional status, this doesn't capture the full breadth of frailty and liver disease. And frailty and liver disease is multifactorial. Some of it is related to the fact that cirrhosis in and of itself is a catabolic state, and so there is a lot of consumption of muscle and poor building of muscle mass, even in the setting of adequate nutrition. There are some data suggesting that hyperammonemia in and of itself can lead to increased muscle breakdown. So patients who have poor synthetic function or a lot of portosystemic shunting related to hepatic encephalopathy can be at higher risk of sarcopenia and muscle loss. But then there's also a big factor of malnutrition, and this can be especially problematic in patients with a lot of ascites, where they essentially don't have room to get food in, and they develop early satiety, and they don't really want to eat. And we see this kind of vicious cycle where patients can develop worsening ascites, worsening sarcopenia, and this is, again, not really reflected in the MELD score. And so in these patients, in addition to frailty in and of itself being a risk factor for mortality, it's also a big impact on patients' quality of life. It leads them to spend more time sitting down, more time sedentary, and as one would imagine, that also feeds into the development of worsening sarcopenia because patients are just becoming deconditioned and not using their muscles. Jennifer Lai and her colleagues out of UCSF have done a lot of work on this and developed a liver frailty index, which includes measures such as grip strength, chair stands, and how long a patient can hold a three-position balance. And using this liver frailty index and adding that to the MELD score, there's a clear increase in mortality among patients who have a higher liver frailty index, such that for a patient who has a liver frailty index that's high but a relatively low MELD score of around 14, their mortality is actually going to be higher than the patient with a higher MELD score, so of 23, who has a lower liver frailty index. So frailty has a big impact on mortality in our patient population. So shifting gears to just talking about the wait list for liver transplant, there's currently around 11,700 patients awaiting liver transplant in the US. As I mentioned, alcohol-related liver disease and metabolic dysfunction associated steatotic liver disease, or MASLD, are currently the leading etiologies of end-stage liver disease driving patients to transplantation. The previous leading cause, Hep C cirrhosis, has been on the decline for years as a cause of cirrhosis and end-stage liver disease because of the advent of direct-acting antivirals. But many of these patients remain at risk for the development of hepatocellular carcinoma because they have accumulated some degree of fibrosis related to their Hep C. And so we still see many cases of HCC that's related to prior Hep C. And germane to this talk, the age of transplants on the waiting list is increasing. So, and this goes hand in hand with our aging population and also the changing dynamics of what drives liver disease. Many patients, for example, with MASLD or fatty liver disease wind up decompensating, later in life, in their 60s or even their 70s, whereas patients, who maybe acquired hepatitis C from drug use in their 20s may develop cirrhosis in their 40s or 50s. So we're seeing a big shift in the demographics of the waiting list. So in 2010, only around 14% of patients who were on the liver transplant waiting list were over the age of 65, and that's these patients now account for almost a third of the waiting list. In addition, we're also more comfortable transplanting patients who are older, and this has to do with improvements, I think, in overall care of patients' comorbidities, including diabetes, hypertension, but also improvements in techniques in transplantation, improvements in understanding of immunosuppression post-transplant. And so many programs that had specific age cutoffs for transplant have sort of done away with that, with, again, the recognition that what we really are talking about when we are worried about someone's age is really their frailty and their ability to recover from a transplant and survive for a good amount of time post-transplant. Now, when patients are older on the waiting list, this is associated with an increased waitlist mortality at similar melds when you compare patients who have a relatively similar meld to those who have the same meld but are older. Those older patients have a higher risk of mortality, and that's probably because, again, in part of frailty and in part because they have probably accumulated more comorbidities as they've gotten older. In addition, patients who are older at the time of transplant have a relatively lower overall post-transplant survival, and again, related to probably comorbidities and frailty. But there's actually no difference when you look at the survival benefit. So the expected amount of time that person gains with a transplant is similar to what one would expect with transplantation of a younger patient. So this serves as the justification for still transplanting patients who are a bit older. Older age is not in and of itself a contraindication for transplant, but we do have to take into account what the patient's comorbidities are and how frail they are at the time of transplant. Okay, so we'll shift gears now to talking about specific symptoms that we may see in decompensated cirrhosis and their management. And so we'll talk about hepatic encephalopathy, ascites and volume retention in general, portal hypertensive bleeding, and pruritus. So most of the complications that I just read out are related to portal hypertension with the exception of pruritus. Just to briefly review the pathophysiology of portal hypertension, when you have someone who has advanced cirrhosis and they have extensive scarring through their liver, you have increased resistance in blood flow through the liver. That then leads to increased mesenteric vascular congestion and relative hypoxia in the gut. And this is compensated for by an increase in arterial flow through the gut, so an increase in splanchnic blood flow. So portal hypertension is driven by this combination of increased resistance within the liver and increased blood flow on the splanchnic arterial side. And this is a process that feeds into itself. So when you have increased splanchnic vasodilatation, you also wind up with systemic vasodilatation. That is early in cirrhosis compensated for by an increase in cardiac output. But as time goes on, this sort of feeds into itself and you get worsening peripheral vasodilatation and eventually a decrease in your effective circulating volume, which then leads to activation of the renin-angiotensin and aldosterone system, leading to excess salt and water retention by the kidneys, and also the non-osmotic release of vasopressin, which leads to increased water retention over the amount of salt retention, and that's what drives the development of hyponatremia. And so, when you have this severe portal hypertension and this hyperactivation of the renin-angiotensin-aldosterone system, you not only get the manifestations of portal hypertension like varices and ascites, but because the RAS system is so activated, you also get renal vasoconstriction, and then that leads to hepatorenal syndrome. Hepatic encephalopathy in cirrhosis is driven primarily by two underlying processes. So there's synthetic dysfunction that occurs within the liver, leading to impaired clearance of ammonia via the urea cycle. And also, in order to decompress the portal hypertension, you develop portosystemic shunts like esophageal varices. And so when you have portosystemic shunting, ammonia and other toxins are going to be shunted away from the liver into the systemic circulation, and then that can cross the blood-brain barrier and lead to changes within astrocytes and other glial cells, including conversion of glutamate to glutamine, which can cause osmotic changes within those cells. You can also develop the creation of atypical neurotransmitters with overactivation of GABAergic receptors, leading to the sedation that we often see in patients with hepatic encephalopathy. Hepatic encephalopathy is traditionally graded by the West Haven criteria. So, grade 1 encephalopathy can be very subtle, subtle changes in affect, difficulty concentrating, or impaired performance on mental status testing. Grade 2 is when we start to see overt signs of hepatic encephalopathy. So, drowsiness, disorientation. You can see the physical exam finding of asterixis here. And then grade 3 and 4 are sort of progression into somnolence and hepatic coma. Um, we can define hepatic encephalopathy as episodic, occurring sort of infrequently, recurrent, or persistent. Persistent hepatic encephalopathy can be very problematic, and this is where patients may not, even with appropriate treatment, may not return to their baseline mental status. So when we are managing someone with hepatic encephalopathy, we first have to think about whether there's something precipitating it. So the most common precipitants of hepatic encephalopathy include GI bleeding, infection, and so this is why when we talk about ascites, I'll mention that any patient who has cirrhosis and ascites and who's coming in with hepatic encephalopathy should have a diagnostic paracentesis to rule out spontaneous bacterial peritonitis, because this is a very common trigger of hepatic encephalopathy. Electrolyte abnormalities, and especially among patients who are on diuretic therapy, can be a trigger for hepatic encephalopathy, as can constipation and dehydration. If someone has never had an episode of hepatic encephalopathy in the past and they're coming in with a new diagnosis of this, they should get some brain imaging just to make sure there's not some CNS process that is driving their altered mentation. And then we start treatment for these patients. So lactulose remains tried and true. It's still first line for the management, especially of acute hepatic encephalopathy. Someone's coming in acutely confused, especially if they have grade 2 or grade 3 hepatic encephalopathy. They should get relatively aggressive treatment with lactulose, having it dosed every 1 to 2 hours until they have a bowel movement, after which it can be, the frequency of administration can be decreased such that they have around 2 to 3 soft bowel movements per day. We do want to avoid overdosing with lactulose, where patients wind up developing diarrhea, because this can then lead to dehydration and hypernatremia, which in and of itself can trigger and worsen hepatic encephalopathy. So there is a bit of a therapeutic window there where too much lactulose can also be a bad thing. Many of our patients who have had recurrent hepatic encephalopathy benefit from rifaximin. This can be added during an acute episode of hepatic encephalopathy. It can be continued for secondary prophylaxis. Although the most robust data, the clinical trial data, really looked at patients who have had at least 2 episodes of overt hepatic encephalopathy. And it has a fairly good number needed to treat of 9 to prevent a hospitalization from hepatic encephalopathy. Once patients are started on lactulose and rifaximin, it should be continued for secondary prophylaxis and to prevent recurrence. With the exception of there being a very specific discrete trigger for hepatic encephalopathy, like a variceal bleed or an infection, where some patients can be titrated off. If someone has refractory hepatic encephalopathy, this is very rare and should always make us think about whether there's some other process going on. If someone has alcohol-associated liver disease, do they have Wernicke's encephalopathy? Do they have just sort of alcohol-related dementia? These kinds of things should be looked for in patients who have, quote unquote, refractory hepatic encephalopathy. There are a small proportion of patients who have refractory HE who may benefit from embolization of portosystemic shunts, which may lead to hepatic encephalopathy that is out of proportion to the degree of their underlying liver disease. And so that's something that we can look for on imaging and ask interventional radiology to embolize if someone has refractory hepatic encephalopathy. There are more data exploring the impact of minimal or covert hepatic encephalopathy. This is often manifest as just sort of minimal cognitive changes on mental status exams, for example, the Stroop test. It can occur, though, up to 70% of patients with cirrhosis and can be predictive of overt hepatic encephalopathy. it's often worth treating these patients with lactulose and or rifaximin to see if we can achieve some improvement in their executive function and cognitive performance. And this is important because many patients come in and they may not have overt hepatic encephalopathy, but they note, increasing difficulty with their memory. They note increasing difficulty with, instrumental activities of daily living. And so it can be very helpful to treat these patients and achieve some improvement in their cognitive function. There's also data suggesting that treatment of minimal HE can lead to improvements in driving ability, and this is often a difficult subject to broach with our patients who have especially episodic hepatic encephalopathy, because we obviously don't want patients who are encephalopathic on the road driving, but it's difficult to take away someone's independence from driving. And so treating these patients a little bit early can improve their performance, in driving, in addition to other executive functions. Okay, when talking about ascites and edema, this is actually the most common complication that we see from portal hypertension. It's the most common decompensating event that we see. Once it develops, patients' 5-year survival drops to around 50%. And so this can be a harbinger of worsening decompensation and should be an indication for referral for transplantation. Any patient who has a new diagnosis of ascites should undergo a diagnostic paracentesis, especially if they're coming in with hepatic encephalopathy or an AKI, both of which can be triggered by spontaneous bacterial peritonitis. We can grade ascites in a couple different ways. I have here the most common grading system. So grade 1 would be only mild ascites that's just present on imaging. And for these patients, we often don't need to start diuretic therapy. They often benefit from sodium restriction alone. Grade 2 ascites is when you have someone who has obvious ascites on exam with a fluid wave and shifting dullness. In these patients, we often will start on diuretic therapy. And grade 3 ascites are patients who have significant tense ascites, and these patients often need large volume paracentesis. So when we talk about diuretic therapy for ascites, these patients, again, because much of the sodium retention in ascites is driven by activation of the renin-angiotensin-aldosterone system, mineralocorticoid antagonists like spironolactone often will give us the biggest bang for our buck in terms of getting rid of ascites. In the AASLD, the US guidelines, they recommend starting a combination of furosemide and spironolactone. In the European guidelines, they actually just start spironolactone alone and only introduce furosemide in the setting of significant peripheral edema, or once patients start to develop some degree of relative hyperkalemia related to the spironolactone. We typically will start with a dose combination of 40 milligrams of furosemide with 100 milligrams of spironolactone. We generally try to keep that ratio when we're making dosing changes, although that can be individualized to the patient. If someone tends to run hyperkalemic or hypokalemic, we can, increase or decrease the spironolactone component, based on that. We don't want to make changes in the dosing more frequently than about every 72 hours because it takes the spironolactone about that long to take effect. And then once you make a dose change, you do want to get a repeat set of labs in about a week just to really follow the creatinine and the potassium level. And then if someone has a really good amount of weight loss and resolution of their ascites on diuretic therapy, you can actually scale back the dosing to prevent dehydration and AKI once that ascites improves. Complications of diuretic therapy include electrolyte derangements, muscle cramping, which can be very problematic, AKI, including the precipitation of hepatorenal syndrome. And with spironolactone, our male patients can often develop some degree of gynecomastia, and that can be actually painful gynecomastia and may necessitate the discontinuation of spironolactone. And for that, we can usually switch to a eplerenone, which has a weaker anti-androgen effect, or a amiloride. Muscle cramping can be very problematic in patients who are on diuretics. Some people benefit from albumin infusions, tonic water, because of the quinine component of that can often be beneficial, and some will use baclofen. If patients do develop significant AKI or hepatic encephalopathy or hyponatremia while on diuretics, the diuretics should be held. And in patients who have refractory ascites, so if someone is coming in and requiring weekly paracentesis, for example, those patients may just benefit from getting weekly paracentesis, and they're not likely achieving much benefit from being on, let's say, a small dose of Lasix and spironolactone. So in those cases, in the absence of significant peripheral edema, we can often stop the diuretics and just manage them with serial large volume paracentesis. So indications for large volume paracentesis include, grade 3 ascites if someone has tense ascites, especially if they're very symptomatic from it. So if they have pain, if they have really terrible early satiety, or if it's impacting their breathing because they can't sort of open up their diaphragm because of the pressure from the fluid. In those cases, it's helpful to do a large volume paracentesis. One thing to point out here is there's not really any need to correct the INR or platelets. Most of our patients with liver disease will have a slightly elevated INR or thrombocytopenia related to splenomegaly from portal hypertension. The only time we would give any kind of products before an LVP are if someone is very thrombocytopenic, so with a platelet count of less than 25,000. Even with an elevated INR of 3 or 4, as long as that's their baseline and it's relatively stable, there's not really a need to give FFP or other products. This is different in patients who have, let's say, DIC with a new and rapidly rising INR. Those patients may need some correction of their coagulopathy. For large volume paracentesis, and that's defined as a paracentesis where at least 5 liters is removed, it's recommended to give at least 8 grams of 25% albumin per every liter removed. And this will help prevent post-paracentesis circulatory dysfunction, which is a phenomenon where removal of ascites then leads to a redistribution of volume from the systemic circulation back to the peritoneal cavity, and this can lead to relative hypotension and low effective circulating volume, and this can be a trigger in some cases for hepatorenal syndrome. And so it's important to replete their albumin when doing a large volume paracentesis. For every LVP that we do send a fluid cell count and differential to survey for the development of spontaneous bacterial peritonitis. In patients who have refractory ascites, we can sometimes do a transjugular intrahepatic portosystemic shunt, where interventional radiology will go in and place a stent between the portal vein and the hepatic vein to alleviate some of the resistance within the liver and take some of the pressure off the portal hypertension. And there are data suggesting that TIPS may improve transplant-free survival when compared to serial LVP. However, when we talk about TIPS, patient selection is really crucial, and there are a number of, I would say, relative contraindications to placement of TIPS. So someone who has advanced liver dysfunction, so a MELD of greater than 18 or Child-Pugh C, we generally don't like to do TIPS because it can precipitate further decompensation. One of the big side effects of TIPS placement can be hepatic encephalopathy, again, because you're creating an additional shunt through the liver. And so that can lead to additional shunting of ammonia into the systemic circulation. It occurs in around 30 to 50% of patients post-TIPS, although typically can be treated with lactulose and rifaximin. Among those who develop hepatic encephalopathy post-TIPS, around 10% can develop refractory hepatic encephalopathy. And patients who are older are at higher risk of developing hepatic encephalopathy. So in our geriatric patient population, we're a little more hesitant to do a TIPS because of this concern about hepatic encephalopathy. The presence of pulmonary hypertension is an absolute contraindication to placement of a TIPS because when you are putting a TIPS in, you're increasing flow into the right side of the heart. And so if someone has pulmonary hypertension, that can lead to right heart failure. So if anyone has pulmonary hypertension, we don't offer them TIPS. And then other contraindications include advanced renal disease, advanced hepatocellular carcinoma, and portal vein thrombosis is a relative contraindication. It depends on the extent of the thrombosis and really the skill and expertise of the interventional radiologist as to whether they're comfortable placing a TIPS in the setting of a portal vein thrombosis. In our patients who are not liver transplant candidates, placement of a long-term abdominal drain may be beneficial for palliation of symptoms as opposed to, say, serial large volume paracentesis. And this is especially important among patients who may be transitioning to hospice care where insurance may not pay for serial LVPs. The big concern with placement of an abdominal drain is just that it's a nidus for infection. There's a relatively small study that was published a few years ago looking at this, where they saw no difference among patients or in rates of infection among patients who received a long-term abdominal drain versus those who were receiving serial LVPs. So this is an option, but really for patients who are going down a more comfort-focused route. Esophageal varices and bleeding from esophageal varices is a very dramatic and serious presentation of portal hypertension. Varices are present in up to 50% of patients with cirrhosis. And they develop and enlarge at a rate of around 8 to 10% per year. The risk of bleeding from varices is around 10 to 15% per year, and that risk increases with increasing size of the varices, with increasing child puke class, and with the presence of red signs. Red signs are areas on the wall of the varices that are relatively thin and are at higher risk of bleeding. 6-week mortality for variceal bleeding is relatively high at up to 25%. And it's common for patients to rebleed if they don't receive effective secondary prophylaxis with beta blockade and serial band ligation. So if we have someone who has varices, our sort of frontline method of preventing variceal bleeding is with pharmacologic prophylaxis. And this is accomplished by using non-selective beta blockers like propranolol or nadolol, or an alpha beta blocker like carvedilol. The traditional non-selective beta blockers work by reducing both cardiac output and also causing splanchnic vasoconstriction, leading to reduced splanchnic inflow. For both of the non-selective beta blockers, the goal is to just titrate them up to the maximum tolerated dose. And we say to titrate to a heart rate of 50 to 60 because that's about as much relative bradycardia as patients can tolerate. Carvedilol has several benefits over the traditional beta blockers in that it has, in addition to the beta 1 and beta 2 blockade, it also has anti-alpha activity. And that anti-alpha activity leads to vasodilatation within the hepatic vasculature, leading to decreased intrahepatic resistance to flow. And so data looking at relative reductions in portal pressures when comparing carvedilol versus propranolol or nadolol show that there's a more significant reduction in portal pressures with carvedilol compared to propranolol and nadolol. In addition, it's a little bit easier to use because there's a more reliable decrease in portal pressures, and so we don't need to titrate it to heart rate. We don't need to maximize the dose. The recommended dose is 6.25 BID, which is a dose that most patients can tolerate. And so for those reasons, carvedilol is generally considered first line for prevention of variceal bleeding over propranolol and nadolol. The problem with carvedilol is it can lower systemic blood pressure a little bit because of the anti-alpha activity, and so some patients may just not tolerate it. Important to note that when we are talking about primary prophylaxis for variceal bleeding, you only need to do medical therapy with beta blockade or mechanical therapy with band ligation. You don't need combination therapy. So if someone is on an effective dose of beta blocker and they're tolerating it, they don't necessarily need a follow-up endoscopy to follow their varices. For patients who can't tolerate beta blockade, however, they do need prophylaxis with esophageal band ligation. And so this is where we'll go in endoscopically and we'll essentially just tie off the varices. We try to do this at the inflow at the GE junction here, and this can help prevent bleeding from varices. One sort of issue with this is that patients often their varices can't be eradicated all within the first endoscopy session. So they often need serial endoscopy and serial band ligation in order to eradicate their varices. So it requires multiple procedures. When we talk about acute variceal hemorrhage, just like any acute dramatic GI bleeding, most of these patients should be triaged to the ICU. They should be resuscitated appropriately, so to a hemoglobin of at least 7. We utilize a restrictive transfusion strategy, especially among patients who have variceal bleeding, because variceal bleeding is a pressure-driven phenomenon, not a phenomenon that's driven by coagulopathy. And so by over-transfusing these patients, you're filling up the tank a little bit too much sometimes, and that can lead to worsening bleeding. And for this reason, we try to avoid transfusion of FFP and platelets because the data don't suggest that it is beneficial in stopping bleeding, and over-transfusion with products, again, can increase the risk of further bleeding because increased volume just increases portal pressures. All of these patients should receive vasoactive therapy with octreotide, which causes splanchnic vasoconstriction, and antibiotic therapy with ceftriaxone. This is a really important point because antibiotic therapy is indicated not only in variceal bleeding, but in any GI bleeding among patients with cirrhosis, especially if they have ascites. And the reason for this is that GI bleeding increases the risk of bacterial translocation into acidic fluid, but it also increases translocation into the portal vein. And when you are translocating bacteria and bacterial products like lipopolysaccharide into the portal vein, this causes intrahepatic vasoconstriction. So by antibiosing these patients, you're reducing the bacterial load within the portal vein and thereby reducing the risk of further increased resistance within the liver. We often give PPI for these patients just in case they have ulcers in addition to varices. Patients should have urgent endoscopy within about 12 hours of their presentation. In the patients in whom we can't control bleeding endoscopically, we can utilize temporizing measures like balloon tamponade, but this is really just a bridge to a more definitive procedure like a TIPS, which can acutely reduce portal pressures in the setting of variceal bleeding. The final symptom that I'll mention briefly is pruritus, and this can be a big problem, especially among patients who have cholestatic liver disease, like PBC, PSC, chronic ductopenic rejection following liver transplant. And this can be very problematic and have a really terrible impact on patients' quality of life. It's often worse at night, so they can develop poor sleep quality. They can be at increased risk of depression and anxiety, and they can develop skin lesions like prurigo nodularis. The therapy for cholestatic pruritus is often a step-up approach. So while we think that bile acids play a role, they're not the whole story in driving pruritus. So we often will start with a bile acid binding agent like cholestyramine, which can help many patients. But in those who it doesn't, we can utilize other agents. And there's not necessarily a set or guideline for, second versus third line agents for pruritus. It's very provider dependent, but many of us will start with something like naltrexone, which is an opioid antagonist. Sometimes we can use rifampin, although there is a risk of drug-induced liver injury with the rifamycin family of agents. Fibrates can be very beneficial actually in patients who have PBC and PSC for the treatment of pruritus. And in patients who have prurigo nodularis, the dermatologists now are utilizing anti-IL-4 agents like dupilumab, and that can also be quite beneficial for these patients. All right, so I'm going to turn it over now to my colleague, Dr. Widrell, to talk about kind of the disease trajectory among patients who have advanced liver disease.
Oh, great, thank you so much. Taking all of this wonderful information about pathophysiology and management of liver disease, we'll think about how 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 this impacts illness trajectory and how it affects patients and families. So the first point I want to make is that this is a distinct illness trajectory that looks a little bit different than some of the other serious illnesses that we treat. And if you're familiar with the illness trajectory sort of conceptual model here, we have um, uh, liver is most like the end organ failure model, which features periodic decompensations or worsening of disease with an overall decline in functional status. And it's particularly fraught with uncertainty and is unpredictable. Number two, while there is a definitive management of transplant, that's not necessarily going to be something that everyone can have, and it's not clear exactly who will be successful in obtaining one. Um, Roughly 10% of the population with cirrhosis ends up getting transplanted in the US. Um, and there's no bridge like there is with other organs, like with kidney failure and dialysis, for instance. And organs are scarce. There are fewer organs than those who need them, and it sort of plays into this whole uncertainty of what the outcome will be. And then finally, another thing that makes liver disease a little different is that a lot of the etiologies of liver disease are things that are stigmatized, including most commonly alcohol, but also body size or chronic hepatitis, which might be related to drug use at a different time in the person's life. This is just another iteration of the same to underscore how liver disease is different than some of the others. On the left side, you could have years to decades somebody living with either chronic liver disease that's known or unknown, and maybe even cirrhosis and they have not yet suffered complications from it. And then once they do have an decompensating event, the trajectory looks more like the right side of the graph. And each of those dips could represent a complication, including encephalopathy, ascites, bleeding, kidney injury, infection, or otherwise episode of critical illness. And the challenging piece of that is that each time it happens, you're not sure exactly what the outcome is going to be. And in many cases, it could occur over and over again, with one of them being the time that the person either dies or is successful in obtaining a transplant. And this period of time we generally think of as being months to short years, although it's obviously some variability in that. Next slide. I'm putting here a schematic from a communication framework that I think is well suited to discussing this kind of trajectory with patients and families, which is developed by Schwartzy and colleagues, called the best case, worst case scenario, which is a way to scenario plan. So to outline, this is what we're hoping for, and to describe what they might expect in that scenario. This is what we worry about, and to lay out what that looks like. And knowing that the most likely outcome is probably somewhere in between the two. Next slide. This is a slide courtesy of Arpam Patel that shows some of the data from his group, that there are some deficits in terms of the conversations occurring for these folks. Point number one is that there are conversations among patients and families, but most of them occur independent of the medical visits. Number two is that, in part because of the organ scarcity and the sort of severity of the condition, things conversations about end of life care and preferences are often deferred because of either time or focusing on what the positive outcome will be. Number three, there is a sort of idea of discussing death, but as more of a punitive bad outcome. And number 4, generally the focus is, when transplant is on the table, the focus is on the more aggressive treatment plans in order to successfully try to get to that goal. And the implication of this in terms of how it affects folks is that when bad things do happen in terms of outcomes, including death, surrogate decision makers do report that they felt unprepared for the decision making that occurred at end of life. Next slide, please. Thanks. So with that, also want to make the point that family and informal caregivers experience significant amounts of caregiver burden and distress. And these are data to highlight that the symptoms that patients experience do impact the caregiver experience, and the two that are most impactful are hepatic encephalopathy and ascites. Next slide. Symptom burden is high among people with advanced liver disease, and Dr. Krismali outlined pathophysiology and management of many of them. You can see here that it actually, end-stage liver disease looks kind of similar to cancer in terms of prevalence. Next slide, please. Pain is generally undertreated in this population. Here are a few sort of tidbits to keep in mind as you're approaching pain management, if asked to do so. Acetaminophen can be used. The max daily dose is lower than other populations of 2,000 milligrams. NSAIDs should generally be avoided in this population because of the risk of, most importantly, acute kidney injury, but also coagulopathy and other GI irritation. In terms of opioids, the most favorable in terms of not the pharmacokinetics not changing because of liver dysfunction is fentanyl. But fentanyl is problematic because, number one, it's a relatively high morphine equivalent and can't generally be used for people who are opioid naive. And number two, delivery as a patch is relatively contraindicated in the setting of cachexia, which is quite common in end-stage liver disease, and also skin breakdown. Hydromorphone is generally an agent that is used, knowing also, though, that it's still sedating and can potentiate hepatic encephalopathy, and the general principle of start low, go slow definitely applies here. And again, using sedating medications, like including gabapentin, should be done with caution because of the risk of encephalopathy. Next slide, please. And actually, we'll go twice. And so I just want to end with a quote that resonates, I think, with some of the humanistic aspect of what we've talked about here. Because of the intense uncertainty that people face, the concept of hope does come up a lot when we're having conversations with people affected by liver disease. And this quote is particularly resonant by Rosenberg, Arnold, and Schenker, that says that rather than being concerned that hope is so fragile that it can be lost, or powerful that it can overwhelm decision making, clinicians should remember that hope is protective, if not necessary, for managing serious illness. It's fluid, expandable, and persistent. Holding complex, flexible, and diverse hopes enables patients to believe in the unlikely while simultaneously accepting the inevitable. And the role of clinicians is to support both. So for the last few minutes, we're going to just go through a few questions. The first one, I'll jump right in, is an older adult with primary biliary cirrhosis, or PBC, prevents with diffuse relentless itching that is associated with passive suicidal ideation. Which of the following treatments would be least likely to help? So the options are cholestyramine, diphenhydramine, naltrexone, benzofibrate, and skin emollients. And the answer is B, diphenhydramine, because antihistamines are generally not part of the toolbox that we would reach for to treat the type of pruritus that's associated with end-stage liver disease. Next slide, please. Number 2, a 41-year-old patient presents with acute alcohol-associated hepatitis in the setting of a chronic alcohol use disorder that has recently resulted in job loss. They are admitted to the surgical ICU for encephalopathy, pneumonia, and respiratory failure. They're now extubated on day 4, and their mental and respiratory status have improved. However, their kidney function is worsening, and their spouse is at the bedside, asking what is the plan moving forward, which could include all of the following except A, oral daily ciprofloxacin, B, a transplant evaluation, C, naming a healthcare proxy, D, referral to an alcohol treatment program, or E, urine electrolytes. And we will say the answer is A. Oral Cipro would not be something that is used here given the lack of a SBP diagnosis here. Next slide. And finally, number 3, transjugular intrahepatic portosystemic shunt, or TIPS, might be an effective treatment to provide relief for all of the following conditions when refractory to medical management, except ascites, portal hypertensive gastropathy, variceal bleeding, hepatic encephalopathy, or hepatic hydrothorax. And the answer is D, hepatic encephalopathy, because this is actually, in fact, a complication of TIPS because of the increased shunting by design. So that's the end of our talk. Thank you for listening.